Hello, I'm Beth Sheridan from the Ohio State University Wexner Medical Center. I'm the Associate Director of Research for Orthopedics and also a PhD student in social work. I have 20 years worth of experience in research from benchtop, translational, and community participatory research. I'm going to be giving a presentation on the upstream efforts and the power of prevention. For today's presentation, we're going to start with a thought experiment. Okay. So imagine you're walking in the woods and you hear someone shouting. You run over and you see that a child is drowning in the river. You dive in, grab the child, swim to shore, make sure they're safe, and before you can even catch your breath and recover, you hear another shout. It's another child drowning. Again, you jump into the river, grab the child, and swim to shore. As soon as you can do so, you hear another child, and another, and another. So at this point, do you stay there rescuing children from drowning as they appear? Or do you try to prevent the children from drowning in the river in the first place? This is a public health parable commonly attributed to Irving Zola. So here's the big scene of the children drowning. So using the parable one more time, you see the children drowning at the bottom, and upstream in the background, we see the bridge where the children are actually falling through. So the downstream intervention are reactions to a problem that have already occurred. This is traditionally how medicine is treated and EMS has been focused on. Upstream interventions are designed to prevent a problem, like fixing the bridge that the children are falling through. Community paramedicine, or EMS providing non-emergent care to a community, was an expansion of the EMS scope of care. In Ohio, a bill was signed into law by Governor John Kasich on June 30th, 2015, and went into effect that same year, providing the opportunity to EMS to begin thinking upstream. Other examples of upstream thinking is not smoking, not drinking, driving safe, exercising, vaccines. Costs of upstream efforts are significantly lower than downstream efforts and are associated with better quality of life for individuals. Of course, with everything in life, there's barriers. So Dan Heath in Upstream, The Quest to Solve Problems Before They Happen, identifies 3 common barriers to the upstream efforts: problem blindness, ownership, and tunneling. Problem blindness is defined as accepting that bad outcomes exist, so they're going to happen, so why try to change them anyway? Ownership is we didn't cause the problem, so why should we try to fix it? And tunneling is when people have a lot of problems, and so they're so overwhelmed, they don't have the capacity to try to solve them. So they adopt short-term and reactive thinking, moving always in the same direction in a kind of tunnel pattern. Dan does provide some suggestions on how to overcome these barriers. So for problem blindness, you can shift your mentality to not accept that there's only one outcome to things. For ownership, there's the extreme ownership of taking responsibility for improving the outcome because you believe it's worthwhile. That idea of leaving somewhere better than how you found it. Tunneling, you need the structure slack is needed of the time and resources for planning and problem, a reserved space to dictate the upstream effort. Going back to the original parable of the children drowning in the stream, you would need a passerby to come keep on pulling those children out of the river while you go and figure out that it's the bridge that's the problem, so you can fix the bridge while the children are still being saved. So how can we look at this in an EMS space? Well, falls are the leading cause of non-fatal and fatal injuries in older adults. An estimated 1 in 4 older adults experience a fall each year in the US alone. In 2018, that was approximately 36 million individuals. This is expected to increase as our older population increases. By 2030, or by 2030, that's estimated to be about 52 million individuals falling a year. Falls can lead to a profound change in mobility, independence, and overall life expectancy. It can exacerbate underlying health conditions due to lack of mobility. Falls create a burden on the healthcare system. We know that total fall calls and lift assists are going up while transport rates are going down. Quatman et al. In 2018 suggests that when someone calls 911 for a lift assist, this could provide the perfect opportunity for community paramedics to make a meaningful intervention. Snooks et al. In 2017 found that 50% of individuals that called for lift assist would call EMS a second time within 2 weeks. Of those individuals, a third would die within a month. Lift assist cost the community a lot of money. Quatman and Schweitzer estimated the cost to be between $825 to $1,500 a run. That translates into $1.5 million over a 10-year span for a medium-sized community. I'm going to leave you with these thoughts, whether it's a lift assist, fall prevention education, CPR training, eye exam for older adults. Wherever your passion lies, you have the ability to harness the upstream thinking to identify and address the issues that are most important to you and impactful for your community. One of the most meaningful quotes of Dan Heath, I think, is the seed of improvement is dissatisfaction. So take that and think about what makes you unhappy in your community that you can change and make some upstream changes. Here's my contact information. Feel free to email me. I hope you enjoyed my presentation.
Hi, my name is David Wisner. I'm a firefighter paramedic with the Upper Arlington Fire Division. I've been a 911 responder now for about 14 and a half years, working recently with the Upper Arlington Fire Division and our community paramedic program called Upper Arlington Cares. So when you think of the fire department, what do you typically think of? You think of you call 911 and we show up and we help out in whatever situation you need. We show up in big red trucks, whether the house is on fire or you're in a car accident or you're sick or injured at your home, at work, in the roadway, in a field, really wherever. For years, it's been advertised that basically you call 911 and we will show up and help. We help people when they're physically, mentally, and emotionally at the lowest points of their lives with basically anything and everything we can, and, even maybe showing up to help get a cat out of the tree. We help with literally anything, which in turn has created an environment where we're one of the most trusted healthcare providers that can reach people in their homes. So today, part of what I'd like you to understand is just the history of emergency medical services and the transport. It started with somebody would call for help and a technician would show up in a hearse, actually back in the day, and pick you up and take you to the hospital. Then they started doing other things where they could maybe start a little bit of treatments and take you either to the hospital or the doctor. But for the longest time, in emergency medical services, it was basically we would show up and we'd either take you to the hospital or not take you to the hospital, depending on what the situation was at the time. Well, as Beth Sheridan shared earlier, that paradigm is somewhat changing. In 2016, paramedics were allowed to start visiting people in their homes on a non-emergent basis. And in Upper Arlington, we've been doing that through our community paramedicine program called UA Cares, trying to visit people on a non-emergent basis, really trying to prevent injuries and illnesses in the community in whatever way we can. For the longest time, paramedics have gone in the homes and seen situations where, gosh, we wish we could do more than just take you to the hospital or leave you at home. Well, now we're actually able to do that. This case that I'm sharing with you today would be one of those impacts on our patients where they were what's called a high 911 utilizer. meaning he would call 911 sometimes multiple times a day, sometimes for a fall or other situations. But we know him very, very well, know him and his roommates to a point where he knew us by name. We knew him by name. As soon as we walked through the door, knew his medical history, knew pretty much everything about him. And honestly, on the way to the house, knew kind of what to expect when we walked in. Typically, it was he had fallen while being transferred from his wheelchair to his bed. He's a bedbound patient with cognitive disabilities and multiple comorbidities like diabetes and congestive heart failure, as well as communication difficulties, which also led into some of the problems that he was experiencing of either not being able to communicate it to where healthcare providers could understand it, or healthcare providers not being able to communicate well with him. So again, there would be frequent 911 calls, sometimes multiple calls a day, and frequent transports to the emergency room, which also then led to secondary infections and just really an increased pain and suffering for him. So for the longest time, there wasn't much more that we could do other than take him to the hospital or not take him to the hospital. But now with CARES, we're able to start finding where is he falling through the gap in the healthcare silos? What are the things that can be done to bridge those gaps and to honestly decrease the cost of the healthcare system, improve his satisfaction, and improve his healthcare outcomes? With that, we're looking at our data, we are finding that most often we are being called at a specific time. And looking into that and connecting the dots, we were finding that was after home health care had already left for the day. And when he was trying to transfer back from his wheelchair into bed with his roommate, he was falling or and getting injured sometimes or not. And then that would lead to a transport to the hospital. So by looking at that data, we were able to then go ahead and bring together all the stakeholders, physicians, Board of Developmental Disabilities, home health care, as well as us, and talk about the situation and how we could improve it for him. And actually, the answer for this particular gentleman was just increase some hours in home health care. And so we went from multiple 911 calls a day to months without seeing him. And the reality is, it went from showing up to his house after he called 911 and him saying, nobody cares, and honestly feeling that way because it was the same thing every time, to now our paramedics ask, do they live here anymore? Because we just don't see him on that regular basis. Again, as the graph shows, we used to go there multiple times a day, multiple times a month, multiple transports a month, to now we'll go months without seeing him on a 911 basis. On the other hand, we can also dashboard this and see if we've had multiple trips there in a month. Maybe there's a flare-up of one of his comorbidities that we can take a look at and now communicate that back to his visiting physician. So that's happened in the case of maybe a UTI, and then they're able to get him some antibiotics, as well as the nurse for the home health agency follow up on him and prevent, again, that transport to the hospital where he gets secondary infections and things like that. For the healthcare system in general, this also went from him having about $50,000 in medical bills a month and up to $500,000 of medical bills a year to, again, just some increased home health hours, which again decreased the burden on the system in general, improved his satisfaction, and improved his health outcomes, where the visits with him now are no longer nobody cares to just happy and talking about the Buckeyes and other things that he loves in life. One of the things that we've recognized through this, and that was one of our earliest cases that we really became involved in, is what we do and what we all do in the healthcare field. It's about relationships. It's about relationships with our patients. It's about relationships with other healthcare providers. And it's about finding ways to bridge the gaps in healthcare silos so that our patients don't fall through them. As we found as paramedics, we are one of the most trusted healthcare providers and that can be in people's homes. So we feel like we're a very valued member of that team that's sometimes underutilized, that hopefully community paramedicine is changing some of that paradigm. Because the reality is, the way we see it is we own the home. Meaning, basically, people call us again when they're physically, mentally, emotionally at the lowest point of their lives and ask us and invite us into their home to fix it. In the same sense, on a non-emergent basis, when we come to help somebody, they realize and see us as the ones that were just there to try and help them when they were really sick and let us in and talk to us about what's going on. The other thing with that is part of the research that we've been involved in and the focus group studies. People say that one of the things they're so dissatisfied with healthcare is they go to see a doctor, and it's no longer their doctor that they're familiar and comfortable with, but it's also somebody who just sits at a computer, looks at the screen to answer questions, and then they're out the door again as quick as they can to get to the next patient. We understand that. That's just honestly where the healthcare field is right now, unfortunately. But it leads to a lot of dissatisfaction and distrust among our patients. Well, for us, we can go in the home and stay and listen to what's actually going on and take that time to develop relationships with the patients, as well as then bridge the gaps through primary care physicians, physical therapy, occupational therapy, speech therapy, and any other members of the system. With that, one of the things that we started at the beginning was asking patients, what's one thing you would like us to know about you? And that's something we do to this day. And it really helps build those relationships in a trusting fashion to where we then can help them connect the dots and be able to bridge the gaps where they typically had been falling through in the healthcare system. With that, we would love to connect with you through Upper Arlington Cares, or OIPP has our contact information. Again, if you are a community paramedicine, keep up the good work. If you are other members of the healthcare system, keep up the good work. We are all doing it, trying to help our patients in the best way we know how. So continue to fight in the good fight, continue helping your people, and have a great day. Thank you. Bye.
Hello. My name is Joe McCabe, and I've been a firefighter paramedic with the City of Upper Arlington for 17 years. I have been involved with our community paramedic program called CARES for several years, including working as a full-time CP since January of 2021. Community paramedicine is a rapidly growing model that seeks to bridge the gaps in traditional healthcare services. It allows paramedics to take a proactive role in the health of their community in a non-emergent setting. Programs are generally tailored to the needs of a specific community, which may vary depending upon demographics. Commonly, fall prevention, substance abuse, chronic disease management, and several other areas are included in a program. The goal for the community is an improvement in the quality of life and the ability to age safely in place. The overall goal is to reduce hospital admissions and unnecessary 911 calls, resulting in a reduction of medical costs and overusage of an already overwhelmed medical system. Our program in Upper Arlington includes fall prevention as one of the main focuses. We receive referrals from several sources, including from our medics on 911 calls, local PT and OT providers, and by word of mouth. We include recognized fall risk assessments in our new patient intakes and offer free grab bar installations as one of our interventions. As firefighter paramedics, we are frequently responding to 911 calls generated from a fall. These range from a simple lift assist to serious trauma. These responses involve the more frail of our population, including the elderly and disabled. A lot of these people are familiar to us and have had numerous calls for falling, yet our role traditionally has been support after the incident, not prevention. We all easily identify the sick, not sick, and that easily transitions to the frail, not frail. Once recognized, those at risk are identified, and as a paramedic, we have many avenues to help prevent or reduce further occurrences. Fear of falling, unsteadiness, and difficult areas to navigate in the home can have a negative impact on quality of life for people with balance and stability issues. One of the simplest and most effective interventions that we use is the installation of grab bars. Bathrooms are the most common area for us to install bars. There are slippery floors and tall tub sides to step over. Trying to sit down in a tub or shower or standing in a shower area can be very formidable obstacles for someone that may have issues simply walking around their home. That being said, something as simple as installing grab bars in a shower area can make all the difference in the world to these people. Having the option to hold on to something appropriate and sturdy, not a towel rack, and placed at the right height gives an additional added level of confidence and can reduce the anxiety of performing a simple daily task. Another common area for us are doorways. Entryways from the garage into the home are usually only a couple of steps, but they're often short and steep. There's usually nothing to hold on to except maybe a nearby trash can, and the surrounding area is frequently cluttered with shoes and debris. Front and rear doors often have a raised threshold or a dramatic step up to make entry. An easy solution that we employ is to install a small, low-profile grab bar in the doorway. It takes about 10 minutes to put in, is very secure, and the results are amazing as far as how much more confident they feel going in and out of their home. Learning to install grab bars takes little training and basic tool skills that anyone can learn. We use only ADA certified grab bars and tried and tested mounting techniques to ensure their reliability. We have installed hundreds of bars in tile, marble, drywall, and concrete without issue. You will occasionally run into something unexpected behind a wall, but if you use common sense and a good stud finder, you'll be successful. Several factors have kept people from being able to have grab bars installed for themselves. Cost of materials, installation, and the availability of a reliable handyman service included. Firefighters and paramedics providing and installing bars makes things easier. People trust us to come into their homes and know that we are truly invested in their safety. Meeting with the people prone to falling in your area in a non-emergent setting also has the added benefit of getting to know more about their underlying conditions. It allows you to become more familiar with their situation. It also allows them to become familiar with the department that will be responding to them emergently if the need arises and increase their comfort level and trust. It helps us to identify some of the most frail in our community so that we can take a role in their safety and well-being prior to the 911 call. Finally, the people of our communities look to us to keep them safe during an emergency. Firefighter paramedics taking an active role of preventing emergent situations seems like the natural progression.